Ladies and gentlemen, I'd like to welcome all of you to our international live surgery on gastric cancer. It's a commemorative launch of Seoul National University Bundang Hospital smart operating room. This live surgery symposium, we are being connected to the National University Hospital Singapore and Oita University Japan. And this live surgery is relayed through our smart surgeries platform, YouTube, in real time. First of all, I'd like to introduce our operator, Professor Hyung-Ho Kim. Could you show Professor Hyung-Ho Kim? Professor, yeah. Professor Kim, could you give us some opening remark shortly?
Good morning, ladies and gentlemen. I'm very proud and very honored to demonstrate my performance to all my friends in Japan and Singapore. Please enjoy, sit back and please enjoy my operation. Thank you very much for coming.
Thank you, Professor Kim. I'd like to introduce today's agenda shortly. First of all, introduction of operator, and we are getting comments from the National University Hospital Singapore and Oita University. And then our Dr. Seong-min will present our case and also introduce the team, our operating team, and also explanation of a surgical plan, and is followed by live surgery. And many questions and answers will be followed. And our estimated closing time will be 11:20. So the first, I'd like to welcome Professor Jimmy So from National University Hospital. Professor So, can you hear us?
Yes, speaking,
Yeah,
Professor Park.
Yeah, very nice to meet you again. And could you show your venue, and could you explain your venue and some opening remarks to us?
Okay, good morning, everyone. Yes, thank you so much for this exciting event. And thank you for Professor Park for your introductions. And I'd like to say hello to the team in Bundang Hospital, and also from our friend from Oita University, Professor Ito. Good morning to every one of you. Yeah, therefore, right now it's 9 o'clock in Singapore, and where everyone is working, and now we are hosting in our lab in ASTC lab is our Advanced Surgical Training Center. I think where most of you have been. This is our training centers for laparoscopic and endoscopic training, established by Professor David Lomanto, which is next to me.
Yes, Professor Lomanto. Very nice to meet you.
Hello, Park. Hello, how are you? Good. Thank you for joining.
Thank you for coming.
Ask us to join you. Great.
Thank you very much, Professor Romanto. And Professor Ashim Sabir.
Good morning, Dr. Joong Park and Professor Hyung-Ho Kim. It's very nice to see you live, and congratulations on the new facility. It looks great. You've got an S in front of NUH. Essentially, we are sisters and brothers. So we are one and the same. Seoul NUH. So thank you very much for the opportunity to be with you. We really look forward to a good case and learning from your vast experience. Thank you very much, Prof. Kim.
Thank you, Dr. Sabir. I'd like to move on to the Oita University. Professor Joshi Eto, can you hear me? Professor Eto?
Yeah, I hear. Good morning.
Good morning.
Can you hear?
Yeah, yes, very
Can you
clearly.
hear?
Yeah, we can hear you.
Okay, good morning. Good morning, my friend Doju. And good morning, Professor Hyung Kim. This time we are very happy to join this wonderful live surgery and wonderful conference. And today, we have many doctors and medical students. They are very happy to join this conference. And also, good morning, Jimmy, and good morning, Professor Wan. So we are very happy to discuss with you. So today we will enjoy this conference. Thank you very much.
Thank you very much, and I really appreciate you are joining us. So next, Dr. Sa-Hong-min will present today's case and introduce our team. Please, Sa-Hong-min.
Good morning. My name is Dr. Sa-Hong-min. I'm an assistant professor here in Seoul National University Bundang Hospital. It's very honored to be presenting the case and our team. First, today's case is a 76-year-old female with 24.5 BMI. She came to the clinic with a chief complaint of melena. She had a past medical history of hypertension under medication, and she had a total abdominal hysterectomy for myoma 29 years ago with normal labs. Under endoscopy, she showed advanced gastric cancer, Borman type 1 at the cardia. The biopsy showed tubular adenocarcinoma and moderately differentiated. Apparently, the EG junction was saved. Under the stomach protocol CT, it actually showed a 3.6 centimeter subepithelial tumor, not a cancer, but in the cardia with no distant metastasis and no lymphadenopathy. And this is the case, and I'm going to introduce you our team. And we have our Professor Hyung-Ho Kim. Yes. And our first assistant, this is our chief resident in the Upper J Division. Actually, all our residents, they rotate every month. So she's the chief resident of this month. And this is our scopist,
인사해야지, 인사.
Ms. Haejin
Say
Kim.
hello.
She's a very skilled scopist. We actually rely on her very much. And this is our scrub nurse, Mr. Jong Seo, a very skilled nurse. So this is our surgical team at the moment. And we have other personnel, but for the time being, I'm going to introduce just our surgical units. Please enjoy the live surgery.
Dr. Min, Sa-Hong,
Yes?
Sa-Hong, can I ask a question about the case?
Yes.
So this is an interesting case in the junctional cancer.
Yes.
Looks like a CVID type 3. Does the patient have any history of any reflux?
The patient didn't show any reflux, just melena.
Yeah. Any endoscopic ultrasounds performed?
No.
Since we actually first we did the endoscopy and we thought this was an advanced case, so we didn't do any ultrasound. Our protocol is if it's advanced, we don't usually do ultrasound for the endoscopy.
Yes. Yeah. Because I want to ask, because your plan is to do a proximal gastrectomy or a total gastrectomy?
Proximal.
Our plan is proximal gastrectomy.
Okay, thank you very much.
So this is data from Oita. So I'd like to confirm. So the tumor, how long the invasion to the tumors to esophagus? No.
The EG junction was not involved with the according to the endoscopy.
Okay.
Okay, thank you. Any other questions? Email?
Even Dr. Min already showed the case. Professor Kim, could you explain today's treatment surgical plan shortly?
Yes. Here we inject ICG here, the lesion. The lesion is here. Can you see the lesion? The stain? This is a tumor here. But the cardia tumor, but the EG junction is intact. So even this is advanced cancer. The guideline follow the guideline, maybe the total gastrectomy is recommended, but our data and recent data from NCC Japan, even 8 centimeter tumor in upper body, T2, T3 tumor, the therapeutic index around the lymph node 5 and 4, SD, and 6 is a 0. It's mean proximal gastrectomy is sufficient for this case. So we plan to do proximal gastrectomy here. 핀포인트로 바꿔볼까요?
Can I ask a question to Professor Ito? Professor Ito,
Yes, here.
will you do the same operation? Will you do a total or do a proximal gastrectomy in your hospital?
Yes. So my opinion is that we will choose maybe the total gastrectomy, because I would like to confirm that how wrong the tumor size in these cases.
3.6
3
centimeter, and each very equivocal for invasion the G junction. So a little close to the Gibert type 2. So if close to Gibert type 2 and the tumor size is less than 4 cm, according to new Japanese gastric cancer treatment guideline, proximal gastrectomy is possible.
Okay, we agree with your comment. So well, from these findings, we will choose the proximal gastrectomy in these cases.
And this patient, the age is 76, a little old patient.
Thank you.
So, and also we compare retrospective our the institutional data. We compare laparoscopic total gastrectomy and proximal gastrectomy for advanced gastric cancer. 100 total gastrectomy and 80 proximal gastrectomy. The survivor was very comparable, not different. Even advanced cancer, less than 4 centimeter size. So I think proximal gastrectomy is suitable for these patients.
Professor Kim, I saw you using ICG. I think you injected ICG. Is that to look for metastasis, or what's the primary aim here in this case? What is the role for ICG here?
Yes. ICG 바꿔볼까? Pinpoint. Could you change the pinpoint?
네, 핀포인트로 바꿔주세요.
Because for these patients, we are willing to know the
Pinpoint,
exact
please,
tumor
pinpoint.
site, because all the junctional cancer, the most important, one of the most important thing is the resection margin. So we have to know the resection margin, how far from the lesion. So that is a most important reason to use ICG in here. And another reason is lymphatic mapping. So like this. It's not a sentinel lymph node navigation concept. This is a lymph node mapping and localization of the tumor.
Thank you.
Thank you very much. Okay.
And just to introduce, I think today in Singapore, we have a few surgeons and together with us. I think we have Dr. Anton Cheng from senior surgeons, and Chun Hai. Of course, I think you know Dan Chun Hai. I think from Kutik Park
Yes,
Hospital.
very nice to meet you, Anton Cheng and Tan Chun Hai. Very nice to meet you.
Yeah.
Again.
And we also have Professor Email Emil Wu from Vancouver, from Canada. He also he's in Singapore, therefore he's also joining us in these sessions.
Thank you for
Emil?
joining us. Very nice to meet you. Thank you.
Thank you very much for this opportunity to watch.
And we also have our staff and also our medical students. Thank you very much for coming.
Thank you and welcome all of you.
상당히
Thank you.
많이 왔네, 쟤들. 그지? 이거 잡아볼까요? 거기 놓으시고 이거 잡아봅시다. 여기, 아니 여기. 내가 잡은다. 살짝. 긴장하지 마시고. 나 요 화면 좀 더 안으로 좀 밀어주실래요?
And this live surgery is also relayed through the our YouTube platform, the Smart Surgeries, in real time. So you can enjoy this live surgery via the YouTube.
The Koreans are very high tech.
Okay, good.
And our smart surgery, smart operating room, we have state-of-art equipment such as 3D and 4K and NIR imaging and some voice control and integrated system. So,
Wow, I envy you. Therefore, you have both 3D and 4K.
thank you.
And today you're using a 2D and using 4K system.
Yes,
is it?
yes, absolutely. Because we can transmit a 3D system to you, but we wonder how you have big image, good image, when you use 3D. So this time we've choiced 4K 2D. Next time we can use 3D.
Wow.
Okay. Okay, this is a dissection line here, the 4x focus. 피나면 안 된다. 네? 피나면 안
야.
돼요.
Then what's your plan now? You're now going to expose the lesser curvature.
Yes, we are just approaching to lesser curvature here. This, you can see this is a right gastric artery tributaries here. This is a left gastric artery tributaries. This is a lymph node 3A and 3B. So we cut here. This is a dissection line.
Professor
We
So,
have a yes.
how do you think of proximal gastrectomy? How it is also popular in Singapore or not popular in Singapore?
And I asked this question to Dr. Anton Ching, see what's the comment, and before we get back to us, Anton, what's your comments on proximal gastrectomy?
We don't do very many, I don't think. So probably not a very popular choice if you can have other choices.
I think proximal gastrectomy is still early because we still more than about 50% of our cancers are T3, T4. Therefore, for those cases, we have to do a total gastrectomy. But certainly, for early cancers, this is one of the options.
Yes.
Chun Hai, any comments?
저 가까이.
Totally agree with you, Prof. I just did one answer that is GOO and is T4, and we have not seen any T1, T2 for the last 1 year in Korea Park Hospital. So early gastric cancer is a reality in Singapore. So I agree with you that total gastrectomy for such cases will probably be the most beneficial for the patient.
Thank you.
Thanks, Chun Hai. we were curious. I think many of us have visited your
작년에 한
center.
번도 못 봤단다. 춘아이가 그러는데
I heard in
한 번도 못
Bundang.
봤대, 작년에.
Yeah, in Bundang Hospital that many now using 3D system. And therefore I was surprised at using a 2D this morning.
It's for you.
Yeah, you know that I'm a little bit old-fashioned. We're still using 2D system. Yes.
Yeah. Next time we can
How you use
transmit
3D
3D.
in your hospital? But Dr. Tan Chun Hai, they are very used to a 3D system in his hospital.
Yeah, Bundang Hospital, we always use mainly 3D system, but 3D system is the quality, recording quality is as of now not so good as 4K system. So in the near future, if 3D 4K system will be come, we can use the 3D relaying, yes, technically speaking, 3D system, we can use 3D system for live surgery, and you can see with the 3D glass, but today not 3D the conference is not available. So in the near future, we will prepare. Professor Eto, how is the current status of proximal gastrectomy in Japan? Could you
Yes.
briefly?
Yes, the indication of the proximal gastrectomy is, of course, the location of the tumor and the depth of the tumor. Recently, Professor Hyung Kim mentioned the indication of the proximal gastrectomy is expanding the advanced gastric cancer, especially in the EGJ cancers. So now, we are trying this procedure, and we are accumulating the data.
Thank you for your comment.
오케이, 됐다. 됐지? 자, 바로 그래스퍼.
Questions?
이제 오케이. 자, iDrive. Now we are transact upper stomach using staples. 얘가 왜 워크를 안 하냐? 응? 아, 맛이 갔는데? Okay, thank you. 이거 잡아줘야지. 이거 잡아볼까? 오케이. 자, 위에서 살짝만. 됐지? 한 번에 된다. 한 번에 된다. 45 하나 주세요.
Professor Eto, what is the most frequent anastomosis after proximal gastrectomy in Japan?
So we have the two choices. The one is esophagogeginal esophagogeginostomy, including the double tract and the interposition, and the other is esophagogastrostomy. And I think the frequency of the esophagogastrostomy is a little bit higher rather than the another procedure.
Thank you.
이거 바디
Yes,
Ecto, Professor Ecto. Therefore,
Yeah.
esophageal gastrostomy, you mean the direct anastomosis or the Kamikawa
Yes,
method?
direct anastomosis. And in your institute, we make we make it a narrow gastric tube. So to prevent reflux, to prevent the reflux.
Now, though this is a gastric tube that I think I read your articles on this many years ago. Therefore, you tubulize the stomach and to reduce the exit reflux.
45도 한 바꾸고
It's still popular in your unit?
Yes, unit. In unit is this procedure is popular still. No.
How was the result for this, the exit reflux?
Yes, after the introduction of the narrow gastric tube, so the instant of the reflux is getting lower. Yes, we are satisfied with the result at this moment.
What's the size, what's the dimension of your gastric tube?
Yes, the head of the gastric tube is 6 centimeter, and the middle of the gastric tube is 3 centimeter. So we added some devices.
Yeah, though this is a narrow gastric tube. To prevent
Like a cobra head gastric tube.
Cobra head. How about the anastomosis? It's a circular anastomosis?
Linear stapler, using linear stapler. Yes, for 45 millimeter linear stapler.
조금 밝게 해볼까요?
I see. Thank you. Thank you.
여기 잡고. 여기 잡아보지. 여기 잡아보지. 응, 잡아보지. 요거. 많이 잡아. 오케이.
So now you're approaching the station 7 and 8, 9.
자, 4x focus. Yes.
Now in the celiac axis.
Professor Ito. Professor Ito, thank you very much for sharing your experience of tubularizing the stomach.
Yes.
However, our experience from bariatric surgery has been rather contradictory to your experience, because doing sleeve gastrectomies has always increased reflux disease while creating about the same size tube. So do you regularly put your patients on lifelong proton pump inhibitors then?
Yes, some cases, of course, they needed the proton pump inhibitor. And in our hospital, maybe there are 20 or 30 patients needed the proton pump inhibitor. But in the endoscopic findings, we don't experience a severe reflux after this procedure.
Okay, thank you.
Dr. Ashim Sabir,
Yes.
can I ask one question about the sleeve gastrectomy? Recently, in Korea, many bariatric surgeries, because from this year, the bariatric surgery is reimbursed by medical insurance. So we met frequently reflux after sleeve gastrectomy. Could you give us some tip prevent GE reflux after sleeve gastrectomy?
Okay, so first of all, I think you guys have done a great job, and congratulations for being having the insurance.
Thank you.
It's a great role you help your patients. I think few things. Firstly, there is no difference in weight loss between 32 and 42 French bougie. So don't make your sleeves very tight. Angle of his dissection is good, but you don't have to divide that angle altogether. You have to expose it, but you don't have to necessarily take it down. People would divide the entrance, take out a large portion of the entrance, leaving behind only 2 centimeters, which will reduce acid-producing mucosa. Try and avoid stricturing at the incisura, and hopefully this will help you with any reflux issues. For any patient who has reflux esophagitis, In the Asian context, I would strongly say that I would recommend the patient not to have a sleeve hysterectomy. On the other hand, if the patient still wants, I would definitely look for correctable features like the presence of a hiatus hernia, motility disorders, before I actually offer a sleeve hysterectomy, and that too with the proviso that there might be a high chance of reversion to bypass in future.
Thank you for your valuable comments. Professor Eto, do you have any the pyloric procedure if you do direct esophagogastrostomy? Do you have any pyloric procedure, pyloroplasty or pyloric, any kind of procedure?
In the hospital, and I think in Japan, we don't touch the pylorus in this procedure. So I mean, we don't put the pyloroplasty and so on.
Thank you. And Professor Eto, could you introduce your colleagues, especially besides you, Doctor? Yeah. Could you introduce your members?
Ah, yes.
Yeah.
Please.
Hi.
Hi, I'm Kosuke Suzuki. The last time I'm very enjoyed with Shanghai and the
Yes, right.
China, Korea, Japan gastric cancer seminar. Thank you very much.
Very nice to meet you, Dr. Suzuki.
Good morning, everyone. I am Dr. Pipip. I'm a surgeon from Thailand. Now I'm training here in Oita University.
Very nice to meet you. Thank you.
And good morning, everyone. I'm medical student, and my name is Kazuki Miura.
Nice to meet you.
So we have 4 medical students.
Oh, yeah, welcome.
Morning, my name is Takuya Matsumura. Nice to meet you.
Nice to meet you.
Nice to meet you. My name is Sogo Aizawa. I'm 5th grade student. I'm very glad to see your operation. Thank you.
Thank you. Welcome.
Morning, everyone. I'm a student Dr. Kazuhiko Mikado.
Nice to meet you.
Nice to meet you.
Yeah, I'd like to thank all of you for joining us. Thank you, Professor Eto.
Yeah, thank you. Yeah, thanks so much.
And any questions, any comments will be welcome during live surgery.
Now I'm ligate, coronary vein here. Now we are approaching to celiac axis. This particular patient has not too much lymph node enlargement. You can see here the crus here. This is a common hepatic artery, and this is a light gastric here. This is a laminin stomach.
Professor So, Professor Jimmy So.
Yes, speaking.
I want to introduce Guoei Kim from Bundang Hospital. Could you show the outside? 밖에 화면 좀 보이나?
Isaac.
Okay, Guoei Kim will say hello to.
Hello, hi everyone. Hi, Prof. Can you see me?
Yeah. Therefore, you can hear that the ladies are screaming.
I see. Okay.
Dr. Kim. Nice seeing you in Korea.
Just flew back from Singapore.
Oh, wonderful. I heard that therefore it's good to have a family reunion.
Yes. That's what
My goodness. Okay, take care. Yeah, I think that our team here said hello to you.
Oh, who's that? I can't see.
You can see, yeah, we have Li-Ling, we have Li-Ling, Chin, Ingzi, Caris, and Christine, Koi-Min, Corisa, and Papu. All say hello to you. And Li-Ling as well.
Li-Ling especially.
Okay, good.
Thank
Thanks.
you, Corey.
Thank you.
Switch to the operation.
We're dissecting the left gastric artery.
Pinpoint.
This patient BMI is 25.
Wow, Koreans are obese.
Recently, the overweight or obese people are increasing in Korea. So, fusion of bariatric and gastric cancer surgery recently.
You can see the pinpoint is to the lymph nodes. Yes, Chun-Hai, some comments.
Professor Park, this is Chun-Hai here. Can I ask you about your oncometabolic surgery and if there's any results that's coming up from your oncometabolic surgery?
Yes. Thank you for your nice question. Recently, in Korea, metabolic surgery such as sleeve and Robotic gastric bypass are allowed for metabolic surgery if the patient BMI is more than 27.5 and with diabetes. So still the sleeve and gastric bypass are performed. But if we do sleeve, some patient sleeve is considered not enough for metabolic surgery. So we add duodenal jejunal bypass or the proximal jejunal bypass with the sleeve gastrectomy for the selected patient.
I see.
How about you?
We don't have a lot of early gastric cancer to do oncometabolic surgery. So mostly we are just doing a metabolic surgery, and my choice will be a room-wide gastric bypass. The incidence of gastric cancer in Singapore is not as high as compared to Korea. So I think I was discussing with Young-Suk that probably for Korea, probably sleeve DJB or some form of bypass of the intestine will be appropriate for in a place with a high incidence of gastric cancer.
Yes, you're right. So that we are preparing the sleeve plus for the diabetes, low BMI diabetes for metabolic surgery. Yeah, thank you. And if the patient, if gastric cancer patient with diabetes, sometimes we do the long limb Robotic anastomosis for that patient after discharge.
And how long is your long limb Robotic for these kind of patients?
Because the gastric cancer patient is usually not obese, so we just introduce a conventional 50 and 10 centimeter. 50 centimeter for biliary limb and the 100 centimeter for Luli.
Okay, thank you, Professor Park.
Thank you, Tanchunai.
Professor Kim, I think you want to tell us the beauty of this latest technology, the ICT technology. I think this is very, very impressive.
This is, you can see it here. I already transected the left gastric artery here. This is a splenic cellular axis. The common hepatic here, no lamina lymph node here. And this is a splenic artery. This is a splenic artery, small lymphatics here, but this is a lymph node 11D. According to guideline, we don't need to dissect lymph node 11D and 10, but I just remove this lymph node. Stay here.
This is a latest system. You can actually show the lymph nodes by injecting ICG contrast. With this new system of laparoscopic laparoscopy.
Dr. Joong Park.
Yes.
Could I see your OT setup in terms of the monitors? On the screen, we are getting 3 images. One 2D image, we are getting a fluoroscopy image, and we're getting a pinpoint image. So can I see how these images appear to the surgeon in real life? On the screen?
We also see the same screen. Yeah.
So this is on one screen, all 4 images?
One screen.
One screen. The
so
picture
are you
in
using
picture.
a striker system, or this is something that you...
This is a pinpoint system.
Okay,
striker.
R-Strux. Okay, is R-Strux. And ICZ is a pinpoint.
Okay.
It's a different company, but we can integrate 2 systems in one monitor.
Okay, that's interesting.
Yes. Because we have good engineer.
That's awesome. So, Prof, what benefit does a pinpoint give you during your dissection?
At this moment, I don't know not exactly.
Okay.
This is test version. And also we have been involving to develop Korean version of the ICZ system. And now we prepare the test our own ICZ system.
Congratulations.
Professor Kim, so do you have any clinical trial for the evaluate the feasibility of this system?
Yes, now we are planning. We just launched within 1 year for new clinical trial for ICZ. Dr. Kim, he now is preparing for a new clinical trial for ICZ. Yes.
Okay.
What's your plan for the endpoint for the study? I think that this is better for lymph node dissections.
Yes, lymph node dissection. Feasibility of the certain AGC for sentinel node navigation surgery. Because T2 and some T3 tumors, at this moment we had total gastrectomy. We have to total gastrectomy and distal gastrectomy, but some particular patient, we don't know who is optimal, but I think some patient is very good for candidate, a good candidate for sentinel lymph node navigation surgery. That is our primary goal for using ICG system. But Dr. Kim, he now preparing for feasibility test.
I see. But I think just now we see the pinpoint system is really very impressive. We can actually see
this is a left gastric epithelioid artery and vein. This is a root. So I just cut here.
As of now, the indication of NIR system might be 2 categories. One is sentinel node navigation for early gastric cancer, and lymph node mapping for advanced gastric cancer, I think.
Yes, I think the second endpoint is quite interesting, maybe applicable to us as well.
Yeah. For the second purpose, the effective lymph node dissection, overlay system is more effective, like the pinpoint, because under guidance of overlay system, we can do lymph node dissection.
Email, any comments?
ICG가 아예 안 들어왔구나 이쪽에, 그제?
So Dojun, Professor Park, so I have one comment.
Yes?
Okay?
Please.
So some Japanese researchers presented that if the tumor located to the lesser curvature side, the lymphatic flow is so complicated.
Yes.
So yes, that's a big problem at this moment. So we are very expecting the prospective data from the Hyung-Kim, Professor Hyung-Kim.
Sure. Thank you for your nice comments. But your Jacob 0910 confirmed.
Yes.
Lesser curvature, even advanced cancer, the lymph node 10 and 11D dissection is not necessary. Already confirmed by phase 3 trials.
Yes, number 10 is not necessary, but the number 11D is still controversial. So for advanced gastric cancer.
F-cruise, and this is a light cruise. This is a landmark for esophagus. This is esophagus. This is a mediastinal area here. So now we 가봅시다.
Coming from Canada, I really appreciate how excellent your setup is. We certainly don't see very much in the way of early gastric cancer. We do have ICG coming on board, making our breast tool. And so for us, we do very few laparoscopic surgery because of our patients.
Professor Eto? When I attended the JGCN meeting, Suzuoka,
yes.
I saw many abstract, many presentations using NIR imaging.
Yes,
So this is a little a difference, big, not so little, a big difference between the last year JGCA and this year. So what do you expect the future usage of NIR imaging?
Yes, visualization of the lymphatic flow is very important during the surgery. So we agree this concept. But I think the real benefit of this imaging surgery is still in debate. So we are just now we are discussing about this. But I think this is a very informative procedure. Yes, and this navigation surgery may help the safety of the surgery.
And how do you think of robotic surgery? Because in Japan, robotic surgery is more popular than before. So could you give us some talks about robotic surgery?
This I think hard to explain. Of course, the robotic gastrectomy was covered by the national insurance last year. That's why the introduction of this procedure is increasing. From the many data from your country, the Korea, so real benefit is still unknown. So now in Japan, so we are collecting the some clinical data.
Yes, right. Thank you for your answer. Yes, yes.
I think your question is better answered by you. Because Korea have done robotic surgery for last 10, 15 years. Therefore, you have the most experience of robotic gastrectomy in the world. And you have a choice. You can do laparoscopic surgery, robotic surgery. Therefore, you have the luxury of all these options. So nowadays, therefore, what do you think? Do you think what is the real benefit of robotic surgery?
Oh, yes. Still, there is no evidence of a superiority of robotic surgery over the laparoscopic surgery. And as you commented, in Korea, many skilled laparoscopic surgeon and some robotic surgeons. So comparing two surgeries, there is no big difference. But in United States and other countries, rather than East Asia, might be the robotic surgery is more effective for the surgery because they have no many laparoscopic experiences. But in Korea, very unique the status, so no difference comparing to surgery.
For your patients, how do you choose? You choose a laparoscopic surgery or choose robotic surgery for your own patients?
Because there is no evidence of superiority still according to our data, we do not recommend robotic surgery. But if the patient want to undergo robotic surgery, if the patient gets some information from the media and some other doctors comment, but we don't routinely recommend the robotic surgery. So the reason why our number of robotic surgery cases is small is that we do not recommend because there is no evidence of superiority.
Joong, I'll take you a little further than that. Joong, when me and you will become 65 years of age, will the robot keep us younger for long? And secondly, training the next generation where they will have to go through a long learning curve with laparoscopic surgery and litigation will be a problem. Do you think robotics will offer any benefit?
If the cost difference is solved, robotic surgery is because robotic instrument is more developed equipment. So if the cost difference is solved, might be in the near future, robotic will be the majority, I think.
Thank you. So how's the Korean robot coming?
Yes, Korean robot is already launched, but it is similar to the Da Vinci S in the middle of between Da Vinci S and SI. So the original old version, Korean new launch version, so not so competitive between the Da Vinci and the Korean robot. But Korean robot, the cost is a little down, so the benefit is
just a little.
Yeah, cost.
Just a little down.
Yes. The cost is cheaper than Da Vinci. So
that's good.
A couple of institutes introduced the Korean robot, iRobot. It named iRobot, but not many institutions. Are you interested in Korean robot?
As long as it's cheap, I don't mind using it. And as long as you don't restrict the number of instrument used to 10 and you leave it liberal, Whichever thing comes in competition with Da Vinci and offers benefit, yes, we should use it.
Yeah, right. Professor Kim, how is the anastomosis type after proximal gastrectomy? Could you explain?
Yes, we prepare double track reconstruction and for EJ anastomosis, we prepare the circular stapling method. Our data shows the circular stapling method is quite good. The stricture rate and the leakage rate is the same as linear stapling technique. So we prefer the circular stapling method, EJ anastomosis, and then we made a JJ anastomosis and GJ anastomosis extracorporeally.
So, Prof, you do, I would assume you use a 25 circular stapler?
Yes.
And you use Oroville? Prof. Kim, do you use an Oroville?
No Oroville. Sometimes we use Oroville in high type intramediastinal anastomosis. That time we use the Oroville, but mostly intra-abdominal anastomosis we use common circular staple. Yeah, regular circular staple.
Thank you.
Yeah.
Would love to see that.
Yes. So what you say? This is our laparoscopic first-ring cramp.
Prof, you never gave us that one. We were wishing you would give us one of those.
Yeah, sure.
I thought I would get it free of
I will
charge.
send this instrument for Christmas present for you.
Thank you, Prof. Thank you. I love you. that is the best Christmas gift I will ever get.
Yeah, my pleasure.
Thank you, Prof. Go and remember to collect my Christmas gift from Prof.
Okay. Okay. 잠깐만 나볼까? 너무 잘라. 잠깐만 이거 돌릴 수 안 되겠다. 잠깐만 이거 치우고. 오케이. 자 잠깐 다시 하자. 색 조금 빼놓고 the lip position. We need more dissection the distal esophagus first. 쑥 들어가보자. 이거 잡아보자. 살짝만 잡으세요. 오케이. 스트링 크램. 잠깐만, 앰플 크램.
Prof. Kim, what's the length of the bursting device jaws?
I'm not remember. 그거 좀 이거 스패툴라 보기. The jaw length 얼마지 한 저기.
Just trying to see how much esophagus, what length
You
of
mean the
esophagus.
dissection margin?
No, Prof. When you put the clamp, how thick an esophagus or how wide an esophagus can you take? When you put the clamp, so the clamp has a length, right? So just to know roughly how much it could be, but that's fine. It's okay.
Excuse me. 잠깐만. 여기 차 왔지. 먹어도 조금만. 아니 여기.
Dr. Hashim, Sabir, Dr. Sabir.
Yes, sir. Yes, Dr.
What is your the frequent esophagojejunostomy anastomosis, linear stapler or circular stapler in your practice?
So my practice is not so big as yours, but for the more distal ones, I would tend to do linear stapler because I do not have. I have not been gifted my Christmas gift yet, which I look forward to very anxiously. I use the linear stapler technique when it is high in the mediastinum. I would follow your recommendation of doing oroville reconstruction.
In our practice, if the anastomosis level is very high in the mediastinum, we use oval or linear stapler. But this patient is not so high, the anastomosis level, so we do the laparoscope, using laparoscope clamp, horse string clamp.
Thank you.
Samuel, I didn't catch up your questions, please. Okay.
Prof, I was asking with the device that you use to do the purse string, what is the length of the jaw?
Jaw, you mean the jaw length? Jaw length,
yes.
I'm not sure, but around maybe.
We are measuring now.
Maybe 40 millimeter, 4 centimeter.
한번 자 대고
Okay.
자 여기 해가지고 여기 한번 자 보여주세요. 여기 한번. 자 밖에 정면 보세요.
줘보세요.
We saw you measuring. Thank you.
Can you show?
Can
you see?
Okay.
All right. Perfect. Thank you very much.
Okay.
That's the benefit of being on live surgery.
이걸 살짝 들어줘야지. 주세요. 좀 두껍다. 평소보다 굉장히. 환자 조금 굉장히 두꺼우네. 저 이소파우스 굉장히 두꺼워요. 하나씩 올라가볼까? 있어요. 3D가 아니다 보니까 느끼기 진짜 어렵네요. 저희 실로. 그 실을 이렇게 오케이.
Are we in mass? Joong, do you think this device, doing this procedure like purstring, does it have a very sharp learning curve? Is it very steep?
In the world, there are two types of laparoscopic pulse string clamp. One is Reflux from Korea, and the other is endo-PSI from Japan. And the direction is quite opposite. Our direction is left to right, but in Japan, right to left. Anyway, two laparoscopic pulse string clamp, I think it's quite useful for the, we can perform as the same anastomosis as open method. So laparoscopic pulse string clamp is very useful. I think very valuable Christmas present for you.
Thank you very much. Thank you.
Frankly speaking, I'm very familiar using 3D system. This is a 2D system, very difficult to pass through the thread into small hole.
So, Prof, you do see a difference in 3D versus 2D system?
Sorry? In the 3D?
You note, yes.
3D, which one is better, 3D or 2D?
3D.
Yeah, 3D.
What is your choice? Why do you think 3D is better?
3D, you can see it behind the curtain. 2D just on the plain image, but we can see if you use 3D, you can see behind the layer.
Okay, thank you.
As Professor Kim mentioned, using 3D system, depth sensation is quite better. So, for example, the inserting needle, quite easy to insert needle with the 3D imaging system, for example.
Thank you.
밖에 안 남았다. 10분 남았어요. 그지?
How about Professor Ecto? Therefore, in Oita, use 2D or 3D?
Yes, in the hospital we have the 3D system, but in my surgery we use the still 2D. Yes.
What's your reason?
Yes, so 3D room is so limited.
Yeah. I mean, this is relevant to us because in our hospital, Dr. Shabir is designing which system we're going to purchase. Therefore, all your feedback is very important for us to make a decisions. Chun-Hai?
This is Chun-Hai here from Singapore. I use 3D system for laparoscopic room-wide gastric bypass for bariatric surgery. I think it's better for the needle dissection as well as anastomosis. You can see exactly, it's quite clear and it's easy to maneuver with the 3D. And because the room-wide gastric bypass, we have a lot of stitching to do, so it does help.
And there is one problem using 3D system. If we using as more we use a 3D system, we can use a 2D system. Yeah, after.
So that's why.
Yeah.
So that's why for my bypass I use the 3D, and for my sleeve I use 2D.
Professor Kim completed his gastrectomy with lymph node dissection. He is ready to extract the resected stomach.
Thank you.
Alexa, turn on the surgical light. Yes,
So with
room?
So you're going to do...
No room. The surgical light. Alexa,
They dimmed everything.
Alexa, did you turn on the light? Room light?
Sorry, I didn't find a device that would like room light.
Turn on, Alexa, turn on the room light. And turn on, Alexa, turn on the surgical light. Okay, thank you.
Wow, that is real high tech.
Yes.
And Alexa
This is
listens to
a
you.
voice
I'm so
control.
grateful.
Yeah. Voice
I
control.
was wondering what's Alexa. I thought it's Korean words or something. Voice control. What was the name again, Hyung-Ho?
Sorry?
What's the name again? Alexa?
Alexa, I don't know who he is, who she is. Yeah, she
Alexa,
said.
close the light. Alexa, close the light.
Probably
You can see it doesn't
you
listen to
control
us, so it
Alexa
listens to
remotely.
you so well. Prof, what is under voice control apart from lights?
I don't know. I
Table?
I don't know what is the real advantage using Alexa.
No, Prof, what I'm trying to ask is, apart from the light control, which is voice activated, are there any other systems in your any systems other in your OR that are also voice controlled?
Frankly speaking, this is my first time using this room.
This Alexa.
Congratulations on the opening ceremony.
Alexa voice control system is a little preliminary status. So, but we strongly believe this voice control system will be very, very developing. Yeah.
Yes, thank you. That's really, I appreciate that.
잘 깎아가면서 너무 흔들하게 피 옆에 좀 닦고.
If you're happy with the margin?
I wonder the margin is not secure. We need more dissection. The margin maybe. Yeah. Anyway, we checked margin by proton section. 프록시멀 네? 프록시멀 시스템이 나오겠지. 시스템. 프록시멀 먼저 빨리 가자. Tumor is bigger than I expected. Yeah.
Yeah. It looks quite bulky. So, Prof, you're sending a distal margin as well?
Yes, also we check the distal margin and proximal margin same time.
Wow. And your pathologist will process that entire margin?
Yes, yes. And we can also we can discuss with our pathologist in real time by telecommunication between this OR and the pathology room.
Yeah.
Okay.
When we send such a big margin, they tell us which point to concentrate.
They're mostly around the tumor, but sometimes we incidentally found some lesions, adenoma or cyst, small cyst, or another different synchronous tumor.
Okay,
so, yes. So we always check the whole margin.
Prof, can I ask about the ICG? How long ago did you inject it? And it was injected endoscopically?
Mostly same time, in the real time, simultaneous injection during operation. So after injection.
And this is a submucosal injection?
Yes, 15 minutes after injection, we can identify which lymphatic is the basin.
All right, thank you.
근데 봐야 되겠지. 근데 네거티브야? 응? 더 잘라야 돼? 응? 모빌 쓸까 그러면? 응? 더 밀어봐봐.
Prof, I see that like all esophagus, this esophagus also tends to retract back into the mediastinum.
Yes.
So do you have any advice for us how to keep the esophagus lower down?
Very difficult. So we just tagging the suture each corner of the resected esophagus.
Okay.
아니 저기 포지티브 나올 것 같아? 어떨 것 같아? 응? 포지티브 나올 것 같아? 마진이? 그래? 오케이. 자 그거 저 다이섹트 처음부터 가자. 늦자 일단. 조심해. 머리 깨진다. 잡아보. 네거티브 나온다 그랬다. 네? 잘 잡아. 나와. 자, 여기 잡아. 근데 이상하다, 그지? 좀 나와. 왜 이렇게 두껍냐? 소파 없어. 굉장히 띡하다. 알겠지. 나왔어.
릴렉스 좀 해주세요.
그래서 끝으로 풀려가 잘 끝으로 살짝. 오케이. 앞에 터널 사이드. 앞으로 당기면서.
Prof. Kim, can I ask a question?
이렇게 엠비크램 이거 말고 어디 갔어? 보여주세요. Okay. This is a very crucial step. 들어간다. 응? 그죠? 더 갈까요? 먼저 릴렉스 좀 부탁해요. 들어갔어요?
Joong.
Yes.
Joong, there's a question from the audience because Prof. Kim is busy. I won't understand it.
Yes, please.
Why don't you use Oroville in this case, generally for even low esophagus? Is it cost or what is the main factor?
Because we can use laparoscopic pulse string clamp for this patient, we use laparoscopic pulse string clamp the first choice. But if the level is high, so it's impossible to use laparoscopic pulse string clamp. At the time, we use Obil, and because 25 millimeter usage of Obil is quite uncomfortable because 21 millimeter Obil is quite comfortable for insert long pathway of esophagus, but sometimes 25 millimeter Obil, sometimes if the patient is a lady and old patient, the esophagus diameter is relatively narrow, it is uncomfortable to use 21 millimeter Obil, 25 centimeter millimeter Obil. So the first choice is laparoscopic pulse string clamp, and the second choice is Obil.
Thank you.
위쪽으로 살짝만 위쪽으로 레프트로 안돼. This is very unusual. It is very easy to insert ambil, but this particular patient had relatively thick esophagus. It's not distensibility. So it is very hard to insert. 자, 다시 자. Very difficult to insert. Very unusual. I don't know why this patient had a very thick esophagus.
Because it is life surgery, Prof. If it was that simple.
Okay.
It was that simple.
Okay, no. 잠깐만. 오케이. 잡아봐. 꼬다리 잡아. 너무 땡기지. 안 되면 일단은 넣어놨다가 또 빼봐. 씩 빼야 돼. 그거 주겠어. 빼봐. 그래. 이거 말고.
Professor Kim, can I disturb you as well?
Sure.
Prof, would you consider putting something like an iron intern retractor or latent
you mean the
retractor?
liver?
Yes.
The liver retraction? Maybe sometimes it's
Yes, Prof.
Yeah, but we have to wait for confirming the dissection margin because the condition of esophagus is not so good. So this moment we have to wait the frozen section. The margin is
Sure.
lower.
Thank you.
Okay. Okay, season. Okay, take a break.
Thank you.
프로즌 좀 기다립시다. 프로는 얼마나 걸린대? Thank you very much.
And we wish you luck with the margin.
5 or 10 minutes.